Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is post-exposure prophylaxis for HIV, and the speaker is Dr. Shivani Patel. Dr. Shivani Patel is the Associate Professor of Medicine with BJ Medical College and Civil Hospital, Ahmedabad. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, madam. Very good afternoon to all of you. And today's session for RDLS is post-exposure prophylaxis for HIV. A very important topic, and as important as the care of patients is the care of the caregivers or the healthcare personnel who are involved in the care of these patients. So in this session, we are going to first understand what is the system for post-exposure prophylaxis. As we all know that before the advent of HIV, we had a couple of epidemics of hepatitis B, and that is when the hazards of the bloodborne pathogens came to light. So that is also when there were certain practices and certain attitudes like the standard work precautions and the biomedical waste management came into existence. So we're going to enumerate the illnesses which are transmissible occupationally. Whenever, as say at the ART centers or your workplaces, whenever you have a healthcare worker presenting to you who has sustained an injury, so how to go about, how to evaluate the person and how to go about prescribing the appropriate post-exposure prophylaxis, that is what we are going to see. And we will also discuss the follow-up procedures after prescribing the post-exposure prophylaxis. So as I already mentioned that certain attitudes changed, our behavior as healthcare personnel changed with the advent of hepatitis B and later on HIV. And we started becoming more alert, more aware towards the standard work precautions. Considering that each patient is a potential to transmit or to acquire these infections, we adhere to these practices. But despite that, accidents do happen. And that is when the healthcare personnel are posed with a risk of acquiring serious bloodborne infections like hepatitis B or C or HIV. So there are other infections which are also transmitted through blood like malaria, babesiosis or syphilis. But in the healthcare setup, what is our major concern is transmission of hepatitis B, C and HIV. So as we all know that with the advent of full-blown HIV infection and with the advent of measures to scale up the HIV testing and our ART services, more and more people present to the ART centers, to the centers of excellence for getting treatment. And again with treatment with antiretroviral drugs, the PLHIV have begun to survive even longer. So all these factors pose an increased risk of accidental exposures to HIV. So anybody who are healthcare personnel, anybody working in the healthcare setting can reckon to be a healthcare personnel. The emergency care providers, people working in the OPDs or in the wards, in the operation theaters, in the labor room, even the laboratory personnel, all the hospital employees who come in contact with patients, medical and nursing students, they are the healthcare professionals who have an increased risk of being exposed to the accidental exposures to HIV and who might have the risk of acquiring the infection. So before we proceed to see how to deal with a patient who lands in your OPD or at your center with a potential risk of acquiring infection following some accidental exposure. So before we go on with that, we will see a few definitions. As I said, healthcare personnel, any person paid or unpaid who is working in the healthcare setting and who is likely to be exposed to blood or the other potentially infectious materials. That can be body cavity fluids, that can be specific body fluids or tissues or medical supplies or even the instruments, the environmental surfaces that are contaminated with blood. So any person who is likely exposed to this working in the healthcare setting is a healthcare personnel. So what is an exposure? So any event that takes place with a healthcare personnel and that imposes a risk for acquiring bloodborne infection is termed as an exposure. We'll see how much is the risk of infection, because ultimately when we are assessing the person who has been exposed, we will be assessing how much risk the person has of acquiring the infection and how to target it. Occupational exposure is exposure to these potential bloodborne infections, which we already mentioned, which can be HIV, hepatitis B or hepatitis C, that occur during or while performing the job duties. As against that, non-occupational exposure, that is the one that happens outside of the workplace. So it can be a sexual assault or a case of rape or even unprotected sex. We do not have provision for providing PEP in the case of unprotected sex, but we have provision for providing post-exposure prophylaxis in cases of sexual assault as a part of the care package itself. What is a needle stick injury? So this term does not apply only to actually the needles which cause injury, but even to the sharp objects, which can be scalpels or surgical blades or forceps or glass vials. So anything contaminated with blood, any sharp object, including needles, that can accidentally puncture the skin is taken as a needle stick injury. Who is the exposed person? Because here, as we go further, we will be deciding the risk of acquiring infection based on the exposure and the source person. So here, who is the exposed person? The person who is potentially at risk for acquiring HIV infection because he or she has had an exposure to blood or any other potentially infectious body fluid or material during disposing the job duties. So that is an exposed person. Who is the source person? So the person may or may not be identified. Sometimes the source can be unknown, but still it is known as a source person. And the possible source of contamination through blood or the other potentially infectious body fluids. So from whom there is a chance of acquiring infection because of an accidental exposure, we call them source person. So as we discussed that in the healthcare setting, who are all at a risk of acquiring infection, acquiring the bloodborne infection? The nursing staff and students dealing with injections, dealing with sharps all the time. Emergency care providers, a hectic casualty or a hectic emergency room is often a very potential place where a healthcare personnel can acquire injury. Labor or delivery room, surgeons in the operating room, even the operation theater staff, the laboratory technicians, the physicians, because they deal with hollow bore needles all the time, interns and medical students. Usually nowadays we have a lot of awareness, we have programs, we have sensitization programs. Again, there are posters advocating safe practices or standard work precautions. But however, in the initial years, often we used to have a lot of first year residents landing in the medical OPDs or the ART centers with accidental exposures. So because their work would be hectic, they would be unaware, they would be multitasking, and they were the ones who were most prone to these injuries. Dentists again, also healthcare facility cleaning staff, and even the mortuary staff. So the question is, does exposure to a dead body pose any risk of acquiring the infection? Yes. So because we do not know for how much time the blood remains in the liquid state in the arteries and vessels. So whenever there is a PLHIV patient undergoing autopsy, so what is the measure? So the simple answer is standard work precautions should be practiced even while doing autopsies. And clinical waste handlers. See, the problem with clinical waste handlers, and we have a lot of them even coming again and again, they usually are class 4. So they would not be so much sensitized to it. So we have had repeat exposures in the same persons occurring in clinical waste handlers also. Again, when they are handling clinical waste, then the other problem that is posed is that we would not have an access to the source person. We would not know from which source did the contaminated material come. So that again would put the source code as source unknown, and that again would pose a problem in prescribing the post-exposure prophylaxis as well. So now just think over this. A healthcare worker during disposal of sharps from the obs-gynae theater has a prick on his finger after a positive delivery. Okay, there is another case scenario that an internist had a splash of pleural fluid on the face from HIV positive individual. So how to deal with this? Obviously, both the scenarios are different from each other. There is a needle stick injury in one case. There is a splash of pleural fluid on the face. So that must have been just a mucosal exposure in another case. So how to deal with this? How to stratify the risk in a given condition? We will see that. So out of the two, who is at a risk of infection and how much risk is there? That we need to decide once these people come to us. So now we'll talk about exposure. So whenever an exposure has occurred, how much risk does it pose to the healthcare personnel to acquire HIV infection? So there are several factors that we take into consideration. One is the type of body fluid. Okay, that has been contaminated. The instruments might have been contaminated, or the person might have been exposed to different types of body fluids. Do they all pose a risk? So there are body fluids which are considered at risk, and there are body fluids which do not pose a risk, but unless they are contaminated with visible blood, then obviously they will pose a substantial risk of acquiring the infection. So the at-risk fluids will include blood, semen and vaginal secretions, all the body cavity fluids, that can be pleural or peritoneal cavity fluid, pericardial fluid, synovial fluid, amniotic fluid. So whenever there is somebody doing a procedure with aspiration of these fluids, the body cavity fluids, even the cerebrospinal fluid, then it does pose a risk of acquiring the HIV infection. Other than that, if the exposure is through tears, sweat, urine, saliva, sputum, or vomitus, so that answers one of your questions in the pre-test. So these are considered not at risk fluids, but if they are contaminated with visible blood, then yes, we have to consider them as posing a risk for acquiring the infection. So first thing in the exposure is the type of fluid and also the amount of fluid. Very small amount of, say, a drop or two of blood on an intact skin, or even say on a mucosa, may not pose as much risk. But if there is a huge volume of blood, if there is voluminous fluid or blood which the person has been exposed to, then it poses a higher risk. So first thing is the body fluid. Then the route of exposure. So what is the route of exposure? That will again decide the risk of HIV transmission. As we all know, blood transfusion carries, direct blood transfusion with HIV infected blood carries a 98% risk of transmission. Perinatal transmission without any intervention, 20 to 40%. The sexual intercourse, it is something like 0.1 to 10%. As you can see, needle stick exposure carries a 0.3% of risk of HIV transmission rate. So it's only 0.3%. And a mucous membrane exposure is as low as 0.09%. See, as against that, look at the data for hepatitis B and C. So whenever there is a needle stick exposure with a hepatitis B infected needle, then the risk is as high as 30%, and with hepatitis C, it is 1 to 2%. So then, why are we so much worried about HIV? It's a 0.3% risk. Obviously, because there are no vaccines. We have vaccination for hepatitis B, and the message is all healthcare personnel should receive the full course of hepatitis B vaccination, including boosters as and when required. So there are two things, right? The type of body fluid, we already talked about the at-risk fluids, and the route of contact or exposure. So in the healthcare personnel, it would be either a mucosal exposure with a splash of blood that usually would occur in operation theaters or while aspiration, and the needle stick exposure that can occur anywhere in the healthcare setting. So look at this case scenario now. A medical officer presents to the emergency care for evaluation of needle stick injury 2 days ago while inserting an intravenous line to an HIV positive patient. See, before we started having all these programs for awareness and sensitization, this was a very common scenario. That even, see, because of stigma, people used to not turn up to the ART center or the OPD even if they had a needle stick injury, just because of panic and stigma. Post sensitization programs, we don't see this nowadays. Usually all the healthcare personnel, they are aware and they turn up very quickly, well in time. But the question here is that 2 days have elapsed. So now the next part is, what would be the ideal time for intervening? So whenever any healthcare personnel with an accidental exposure comes to us, there are certain questions that need to be addressed. As we evaluate the person, we stratify the risk or we decide what is the risk for contracting HIV in a given setting and what are the factors that might affect the risk. As I already said, what type of body fluid the exposure has occurred with, how much volume of body fluid, the blood or other potentially infectious material has been, the person has been exposed to. Again, what was the duration before which the exposure occurred? So in the given setting, if we give a post-exposure prophylaxis, we should know how effective it would be. Is it too late to start the PEP? What is the ideal time when we should start the post-exposure prophylaxis? And what are the drawbacks of starting PEP? So the question here is, sorry, the question here is, why can't we start PEP in all patients? Sorry. Why can't we start PEP in all patients? Which regimen should be considered? So there have been certain studies over the years. Initially, the study done was, the first drug that the study was done with was zidovudine.
Ma'am, we'll wait for 2-3 minutes. Don't worry. Take your time, ma'am.
Yeah. Okay, sorry. So why can't we prescribe PEP to all people coming to us? There is a rationale for giving PEP, and that is why we need to evaluate first what is the risk of acquiring this HIV infection after a given accidental exposure. Again, which regimen should be considered? As I said, zidovudine was the first drug that was studied in cases of PEP, and they found that there was an 81% safety with zidovudine. Again, what follow-up should be arranged?
Ma'am, let's wait for 2 minutes, ma'am.
Yeah.
Yeah.
Okay, we'll resume now. So there are certain things to be considered before we prescribe post-exposure prophylaxis to the healthcare personnel. Now look at this table. So we have already seen that with a percutaneous injury or a needle stick injury, the risk of acquiring HIV is 0.3%, as against a risk of acquiring hepatitis B, which is as high as 30%. Whereas a mucous membrane exposure poses a 0.09% risk of acquiring HIV infection. Slide, there is a missing slide.
Ma'am, keep pressing the key.
Okay. So what reduces, or what are the factors affecting the risk of acquiring HIV infection? A high viral load in the patient. Say, obviously, a patient who is clinically asymptomatic has a undetectable or a very low viral load. Good high CD4 count is asymptomatic, will pose a lesser risk as against a person or a patient with high viral load. Glove use, as I said initially, that the PPE, the personal protective equipment, is a must in our healthcare setting, and use of gloves. Hand washing and gloves cannot be substituted by anything else. So glove use can decrease the transmission of infection by almost 50%, because there is a 50% decrease in volume of blood transmitted if the healthcare personnel is using gloves. Use of gloves should be encouraged in all strata of healthcare personnel, including the waste handlers. Hollow bore needles will pose a larger risk of acquiring infection compared to the solid bore or the suture needles. So suppose there is an exposure with a insulin syringe needle, which might be a 31 gauge. We all know that the risk of transmission will be very, very low in that case. However, if the healthcare personnel has been exposed to blood contaminated through an 18 gauge needle, then obviously the risk of transmission of HIV is going to be higher. Drying conditions. So how long does the virus sustain itself in the environment? Once there is a drop of blood outside the body, or say in the given needle or the instrument surface or the environmental surface. So there is a 10-fold drop in infectivity every 9 hours. And it will persist for about a week. The virus is known to persist for about a week, but compared to hepatitis B, this duration is still shorter. Hepatitis B virus can persist on surfaces for a very long time. So these were the factors that decide what is the risk of acquiring HIV infection after an accidental exposure. Now, a healthcare personnel, a person from the healthcare setup, lands in our OPD or lands at our center with an accidental exposure. So how to manage this healthcare personnel? First always is first aid. See, there are certain reflexes, like the healthcare personnel might reflexly put the finger in the mouth. This was very common in the pre-sensitization era, but now more so the healthcare personnel are aware of the do's and don'ts. So first aid of the exposure site, that should be managed first. After that, evaluating the person for the possible risk, establishing the eligibility of PEP, counseling should be done as in the other HIV patients. Informed consent and counseling are very much a part of prescribing PEP. Once we assess the need for PEP, prescription of PEP, which PEP is ideal for the given person, laboratory evaluation, which is a baseline evaluation, and as well as we need to follow up the exposed person at certain intervals. So these are the steps of management once an exposed person turns up at our center. So first aid. If there is an exposure to the skin, we should encourage the person, or we should ask the person to immediately wash the wound and surrounding skin with water and soap. Soap is the best antiseptic. It will dissolve most of the lipid soluble viruses, and hence that is the preferred antiseptic. One should not scrub, because that would augment any abrasions whatsoever, or that would augment any mucosal injury if present. We should not use any irritative substances. So use of antiseptics or skin washes or spirit or alcohol that would aggravate any mucosal abrasion should always be avoided. Do not use bleach, chlorine, alcohol, betadine. These are not to be used. Only soap and water. When a person has a splash of blood or body fluids, so again, The area should be immediately washed and no antiseptic should be used. In an unbroken skin, again use soap and water. What if there is a splash to the eye? So the eye should be irrigated immediately with water or normal saline. It is preferable that the person sit on a chair, head tilted back, and then a colleague can pour water or saline over the eyes. If the person is wearing contacts, leave them on because they will provide a layer while irrigating and will help protect the eye. Once it has been cleaned, then the contacts can be removed and cleaned in the routine manner. Obviously, no soap or disinfectant in the eye. If there is a splash in the mouth, which would not occur much if there is use of mask, but still, if there is a splash to the mouth, then spit the fluid out immediately, rinse the mouth thoroughly using water or saline and spit again. So that is the first aid that needs to be done first. As I said, certain reflexes have to be blunted. So one should not put the prick or the cut finger reflexly in the mouth. So the question that we asked earlier, that a person turns up after 2 days. So what is the ideal time or the preferable time for starting PEP? PEP must be initiated as soon as possible, preferably within 2 hours of exposure and best within 72 hours. The studies have suggested that, see, we all know the HIV life cycle. So once the virus enters the CD4, it replicates and then starts budding and gets released into the bloodstream. That period is a 3-day period. So it is best to target the virus in these 3 days. So what do we do? Assess the severity of exposure, risk of transmission. The second thing is assess the HIV status of the source person. So one is the exposure code. That is the person who has been exposed. What is the risk of transmission? The other thing that we are going to see is the source code. What is the status of the source person? So how do we categorize the exposure? See, suppose there is an exposure to mucous membrane or a non-intact skin. There might be small abrasions. There might be eczema. On a visibly intact skin also, there might be certain skin lesions with small volumes or contact with the mucous membranes or eyes or subcutaneous injections. As I said, okay, the ones that we used in the insulin syringes, 31 gauge needles, very small bore needles. All these are considered mild exposure. Exposure to mucous membrane with large volumes of blood or percutaneous superficial exposure with a solid needle, that is a suture needle, or a superficial cut with not much of blood, just a superficial cut or a needle stick injury, which is glove penetrating. These all constitute moderate exposure. So what poses severe or high risk? Percutaneous exposure with a large volume of blood, with a high caliber needle, say with visibly contaminated blood. If you have a 18 gauge or more needle, then again it's going to be a severe exposure. Or suppose sometimes while dressing the wounds, the residents turn up with a deep wound, hemorrhagic wound with a transmission of significant volume of blood, or an accident with material that has been used intravenously or intraarterially, something used directly in the vein or artery. All this comes under severe exposure. So there are 3 categories. Is that clear? Mild exposure, moderate exposure, and severe exposure. The source code, patient may be HIV negative. Again, still we have to keep hepatitis B and C in mind. Low risk, that is HIV positive individual, but clinically asymptomatic, undetectable viral load, or say a very high CD4 count, that poses a low risk. Whereas some who has an advanced full-blown AIDS with multiple opportunistic infections, with a very low CD4, who is clinically symptomatic, with a high viral load. So that source patient is going to pose a high risk. Now, what are the initial steps? So we will see stepwise how to approach such a patient. As I said earlier, informed consent, appropriate information on PEP. It should be clear that PEP is not mandatory. It's actually a mutual decision. Mutual decision between the prescribing doctor and the healthcare personnel. Again, one should be clear and give clear information on window period, baseline tests, safety and efficacy of drugs. Psychological support, the trauma, the stigma associated. Am I going to acquire the infection? That question itself poses a lot of trauma. So every exposed person should be informed about the possible risk and the measures that can be taken. Documentation on record is essential. At our center, till January, we have had 970 cases of exposures reported. Till date, no seroconversion has been reported. At the end of 6 months, that is at the end of 24 weeks, 854 patients have turned out negative. Still 39 are in the window period and some 77 are still awaiting their 6-month testing. So that is our data. If we have a record, then probably we can look at it and improve measures, improve awareness, improve sensitization. So in case of deciding on the PEP regimen, availability for prescription for PEP and vaccination for hepatitis B. PEP is given as a part of overall package of post-sexual assault care. So start PEP first. HIV testing of the source patient should not delay the PEP. In case of high-risk exposure, again, the source patient who has been exposed to, whether he is taking ARV or antiretroviral medicines, that also needs to be considered. So again, test the sources for all the three: HIV antibodies, HBsAg and anti-HCV. Direct viral assays are not recommended. Again, if the source person is not infected with a bloodborne pathogen, baseline testing or further follow-up of the exposed person is not necessary. Unknown sources. This particular class, say this particular source code poses a substantial problem in prescribing PEP also, because evaluating the likelihood of an exposure to a source at high risk for infection. Consider likelihood among the patients in the exposure setting. Consider the epidemiology in the given region or in the given exposure setting. What would be the likelihood of the source being positive? So that again becomes presumptive. So coming back to when should PEP be started, as I've already said, efficacy of PEP would be maximal if started early. Ideally, the first dose, we should not wait. The first dose should be prescribed and given within the first 2 hours. That is ideal. Within 72 hours, there has been a reasonable efficacy. But efficacy of PEP is thought to wane with time. Once the virus starts budding from the cell, enters the bloodstream and targets the other organs, then the efficacy of the post-exposure prophylaxis wanes off. So this is the HIV cycle. I've already talked about it. So once HIV replicates in the CD4 cells and before it is released into the bloodstream, that is the period of 72 hours is vital, is crucial, and that is the time when PEP should always be started. Now, suppose a person comes after that, comes to you on the 4th day. What should you do? Should we give them or should we not give them PEP? So there is no definite cutoff. Beyond the 11th day, virus starts spreading to the other organs. But more than 72 hours, we can still prescribe PEP once we have evaluated what is the risk of transmission, giving full knowledge to the exposed person that it might not be as efficacious. So, see, actually the studies that have been done for PEP, the sample sizes would be very small because these are healthcare workers who are being accidentally exposed. So largely the derivations or the inferences that we have got are from animal models and case control studies with smaller samples. So animal models, they suggest substantially less efficacy of the PEP beyond 24 to 36 hours. In the case control study here mentioned here, that is Cardo DM et al., most subjects in each group received PEP within 4 hours. I've already told you that after our extensive sensitization programs, we have most of the healthcare personnel coming to us well in time for their first dose of PEP. However, there is not a clear cutoff as to when the PEP totally fails. Again, for how much duration? So initially, as I said, the PEP only zidovudine based trials were there. They studied one drug or dual drug regimen. Eventually, we have a 3-drug regimen. And for the duration, 28 days were more effective than a 10-day or a 3-day of PEP in the most of the studies, and that is the recommendation by CDC also. So our PEP regimen is a triple drug for 28 days, that is 4 weeks. Okay, so PEP should be started preferably within 72 hours of exposure. So what happens is the ART centers may not be working 24 hours. So the best thing is to have the first doses available everywhere, like in places where there is a highest risk of acquiring accidental exposure, that is in the emergency room, labor room, intensive care unit, or the operation theaters. And the exposed person should know where to go. They should go to the designated clinic or the officer. In our setting, they go to the emergency medical unit. So, under what circumstances should you make an expert referral? Delay in reporting exposure more than 72 hours, or the source is unknown. So whenever the source is unknown, as I said, it has to be a case-to-case based decision in that setting. But if PEP is indicated, it should not be delayed. Now, there may be a setting where the source person has already failed treatment, say first line or second line failures. In that case, again, we need to make an expert referral because the PEP, the routine PEP that we prescribe might not act in the given condition. Again, when there is a major toxicity, you should make an expert referral. Or if there are, say, we have seen when efavirenz was used as the first line or as the PEP, we have seen a lot of patients landing with, or a lot of healthcare personnel or the exposed persons landing with CNS side effects. So if there are major toxicities, again, you should make a expert referral. So this is again the same stratification that we saw: mild, moderate, and severe exposure. Mild is exposure code 1, moderate is exposure code 2, and severe is exposure code 3. And source code HIV negative. If the source patient is HIV negative, PEP is not required. Still, window period should be kept in mind. Source code 1, source code 2 and source code unknown. We have already talked about it. So now putting together exposure code and source code, we will see what are the recommendations of PEP. If the exposure code is 1, source code is 1, PEP may not be warranted. Exposure code is 1, 2 or 3 in all, and with a source code of 2, or say in a moderate or severe exposure, any source code, then PEP is recommended for 28 days. When the source is unknown, so consider PEP if HIV prevalence is high in the given population. This poses a larger risk. Usually, if there has been a moderate or severe exposure in a setting where the likelihood of HIV transmission is more, then it is wise, it is prudent to prescribe PEP. What are the regimens available? So there are, in case of adolescents and adults more than 10 years, more than 30 kg weight, the preferred regimen is TLD, tenofovir, lamivudine and dolutegravir. Alternative regimen. So if it is not available or if it is contraindicated, then we can still give TL-LPBR or TL-efavirenz. But however, now most of the cases we prefer TLD. Children more than 6 years and more than 20 kg in weight, the preferred regimen is ZLD. And if hemoglobin is less than 9, then you can give an abacavir based regimen. Less than 6 years, less than 20 kg, you cannot give dolutegravir, so you give zidovudine, lamivudine, lopinavir, ritonavir, ZL-LPBR, and if hemoglobin is less than 9, then you give a abacavir. As I said, the first dose after evaluation with a baseline testing, pending reports should be given preferably within 2 hours. These are some of the side effects. So counseling for side effects is an important part of counseling, because otherwise what will happen? The healthcare personnel may stop the PEP on their own. So if they've been counseled that they will eventually, the side effects will go away or they will last only for a couple of weeks, then they might adhere to the regimen better. So nausea, headache, diarrhea, fatigue, CNS side effects, rash, fever, jaundice or abdominal pain. So these are the side effects that can occur. And if the person, if the healthcare patient or if the healthcare personnel are already counseled about it, they might approach you. So if they approach you for the side effects, then they have to be treated symptomatically, managed accordingly. And that would be a better thing to do for better adherence to PEP. What about hepatitis B? So what is the state of vaccination? That you ask first. If the person has never been vaccinated, give a complete hepatitis B vaccine series. If the person has been vaccinated, but anti-HBs, usually at our center, we do the anti-HBs. If it is less than 10 international units per liter, then we give hepatitis B immunoglobulin. But if it is not available, if the status is not known, give hepatitis B vaccine booster. Vaccinated more than 5 years ago. So if the person has received vaccination 5 years back, again give a hepatitis B vaccine booster. Lab investigations. So what are the baseline investigation? So when you are prescribing PEP, HIV, HCV, HBsAg, CBC, serum transaminases, especially if you're giving these drugs, lopinavir, ritonavir, again, there can be asymptomatic elevation of serum transaminases. Sometimes they can be symptomatic too. So these are the baseline recommendations, baseline investigations that we need to do. And in people or in the healthcare personnel who are not candidates for PEPs, just a baseline HIV, HCV and anti-HBs AG can be done. Exposed persons need to be counseled for repeat testing at 6 weeks, 12 weeks, and 24 weeks. So again, studies have found that most of the seroconversions, they have occurred within 24 weeks. Beyond 24 weeks, the chances of seroconversions are very, very negligible. Clinical follow-up, if there are any signs of seroconversion, so again, we have to counsel the healthcare personnel to be vigilant for these signs. So if there is any acute fever or generalized lymphadenopathy, cutaneous eruption, pharyngitis, or flu-like symptoms, then they should report to the center. They appear in 50 to 70% of individuals with a primary HIV infection, and this usually occurs between 3 to 6 weeks. So monitor for acute seroconversion illness within 3 to 6 weeks. If suspected, the person should be referred to the ART center. Again, while the person is on PEP, they should avoid blood donation, breastfeeding, avoid pregnancy, barrier contraception should be advocated, and adherence and adverse drug reaction counseling is an important part of prescribing PEP. The laboratory follow-up, we already talked about this. On weeks 2 and 4, get a CBC done, especially for patients on zidovudine, and a fasting or random sugar for patients on dolutegravir, serum creatinine on patients of tenofovir-based regimen. Weeks 6, 12, and 24, we have to get HIV antibody testing done. So the care pathway includes assessment or evaluation of the individual first, including first aid, management of the person, followed by counseling and support. That is actual discussion of the risk of HIV transmission, the risk and benefits of post-exposure prophylaxis, the possible side effects, and enhanced counseling if PEP is to be prescribed. The actual prescription of the PEP for 28 days and follow-up. So most of the exposures have occurred during use of sharp instruments, as you can see in this report. For needle stick and sharp object injury, 52% of the exposures occurred during use of the sharps. A quick word on recapping of needles. Say no to recapping of the needles, because that is again where there is a very high risk of accidental exposure. As you can see here, disposable needles and suture needles, they are a cause of accidental exposures in the healthcare setting, and therefore anybody dealing with this, we tell our residents that if you have any sharps in your hand, you leave everything aside, first deal with it, dispose them off safely, and then go on to the other task. So recapping needles should not be done. While transferring body fluids between containers, again there is a risk. Say somebody has drawn blood from the vein and then is transporting them to the vacuity. That is again when there is a risk of exposure. Handling and passing needles or sharps, failing to dispose of. Ideally, every injection trolley should have a needle shredder. So there and then the needles can be shredded and disposed of. No to recapping again. Strict compliance to standard workplace precautions. As they say that prevention is better than cure. Avoid use of injections where it can be avoided. Avoid recapping. Proper disposal of the sharps in the disposal containers. So biomedical waste management guidelines should be adhered to very strictly. Trainings, awareness, sensitization programs to prevent or to minimize the risk of transmission of HIV. Use devices with features, and again a record of the injuries is a must. Hand washing before and after all medical procedures. So hand washing should be a practice that is religiously adhere to use of personal protective equipment wherever necessary, gloves, masks, goggles, aprons. So post-COVID era, we have learned to use the personal protective equipment very effectively, and safe disposal of the contaminated waste. So these are a few situations where there can be an accidental injury, and with safe practices, we can avoid that. Thank you.
Thank you so much, ma'am. I'm taking questions from the chat box now.
Yeah.
Participants are requested to either unmute their mic and ask questions, or they can put them in the chat box as well. Ma'am, there's a question. Can we give guarantee of negativity after PEP?
Sorry?
Can we give a guarantee of negativity, that is HIV negativity after PEP?
No, we cannot, because as I said, there are studies, as I told you about the study of zidovudin, that there was only 81% efficacy. So you cannot give 100% guarantee of negativity after prescribing PEP. So based on the regimen prescribed, we minimize the chances of transmission of HIV infection, but it cannot be totally done away with.
What is the lifespan of HIV?
So usually the virions, the lifespan, actually we see an individual HIV virion, it is only 60 minutes, but within those 60 minutes, it is more about the rate of replication. So it is more about the rate of replication, that it goes on replicating so rapidly that the HIV virus would spread so rapidly throughout. And whatever we have said, that outside the body, if there is a fluid, then the drying, with the drying of fluid, there is a tenfold decrease every 9 hours, and still it can stay alive up to 7 days.
Ma'am, why is PEP given only for 28 days?
If you had seen the slide, it has already been described. See, there were various studies carried out across the globe. In US, the NHS, in Australia, there were certain studies in Africa. So the animal model studies, as well as the human case control studies, they have studied various durations of PEP and the risk of acquiring HIV infection. It was already mentioned in that they have studied giving PEP for 3 days or 10 days or 28 days. Ultimately, it was found that a 28-day regimen and a 3-drug regimen that had the highest efficacy in cutting down the risk of transmission of HIV. So these recommendations come from CDC, and they come after a lot of studies. Unknown source PEP recommended or not. So if you had seen the slide of unknown source, I've already mentioned that whenever there is an unknown source, but there is a moderate to severe exposure, then you have to consider the prevalence of HIV in the given setting. What is the risk of prevalence, or what is the prevalence of HIV, and what is the risk of transmission? So it is not that we don't recommend PEP in that condition. If it is a moderate to severe exposure, we have to consider PEP, consider giving PEP to the exposed individual, considering the prevalence of HIV in that given setting. So if it is our, say, ward, and from there is some needle, hollow bore needle, and somebody has acquired say needle stick injury, then we would have to consider giving PEP in that patient. Next.
Any more questions from the participants? Please feel free to unmute your mic. Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Thank you. Thank you so much.
Kiran sir, can we quickly run the feedback form? Participants can continue putting questions in the chat box. The feedback poll is now visible on your screen. There are 4 questions in all. Please answer all the 4 questions. Thank you to all the participants for patient listening. Kiran sir, we can end the e-poll now. Thank you to everyone. We'll conclude the session now. Thank you.